welcome to this special episode of Virus to Vaccine. I'm Zaka Jacob. India is going through the ravaging second wave. The good news is more than 20 states are now showing a declining trend. There are still some states in the southern part which are showing an ascendant trajectory as far as daily COVID cases are concerned. But the good news is most states are now showing a descending trajectory as far as the second wave is concerned. And already there are two concerns that stand out. One, of course, post-COVID complications, which a lot of patients seem to be complaining about. Chief among them is mucormycosis, so-called black fungus. And then, of course, there is the possibility, which many folks are already warning, of a third wave, which could potentially infect kids. So to discuss this and a lot more around the second wave, around COVID-19 and India's response so far, I'm joined by the Chief Scientist of the World Health Organization, Dr. Soumya Swaminathan. Dr. Soumya Swaminathan, thank you so much for speaking with us here on CNN News 18 on this special broadcast. So first, let me start with the second wave. We had a mere 8,000 cases or so in the last week of March, and suddenly in the last 6 weeks or so, India has jumped up to almost 5 lakh cases. What is your assessment of the way in which India has dealt with this second wave so far?
So what we've seen in India, we've seen in many countries in the past. Unfortunately, I mean, this is the natural behavior of the virus. It's looking for opportunities to spread. And it's basically likes to have people in close contact, people crowding together, especially without masks, people gathering together for social functions. And it is able to then spread itself from one person to the next. I mean, let's remember that this virus mainly spreads through close contact and droplet transmission. So all of these things happened, and the virus also had the opportunity to evolve and mutate. And as you know, viruses, every time they multiply or they replicate, they introduce some errors while doing that. That's what is called mutations. And then a combination of these is called a variant. And the WHO has been tracking variants across the world thanks to large data platforms like GISAID, in which scientists have been uploading their genetic sequences. India had been sequencing relatively less as a percentage of the total number of cases till recently, and now that's being ramped up. So some of these mutations and the new variants, the B117 that was first identified in the UK had become predominant by January of this year. And the B1617, which had initially been detected in October 2020 in India, gradually has been increasing and is now overtaking all the other variants and is becoming predominant. That just means that, you know, the virus changes itself to become more transmissible. But unless we give it a chance to spread from one person to the other, it can't do that.
No, so I'm curious about this B1617, because that is being called informally, certainly, the Indian variant, even though the WHO doesn't classify variants by geography. I'm just curious about the B1617 because many are calling it a double mutant. Many are saying it's highly infectious, more infectious than the other strains that we've seen. I'm just curious to know if WHO has done any studies, genome sequencing of B1617. What do we know in layman terms about this strain, and how different is it from what we've seen in other parts of the world?
Sure. So the WHO, as I said, has been tracking variants, and we classify them as variants of interest when they're reported from a country, you know, which is reporting increasing seeing of this variant. And then we have criteria for calling it a variant of concern, which is either that it should be shown to be more transmissible, associated with more clinical severity, or associated with resistance to antibodies or to vaccines. And so early data that's coming from the B1617 variant, which by the way is getting complicated because there are 3 sublineages. So 617 is divided now into 0.1, 0.2, and 0.3.
Correct.
But the 0.2 looks to be the most prevalent and rapidly increasing. So this has also been studied in the UK because 617 is also now the most rapidly growing variant in the UK. So there are a lot of studies going on there as well as in India. What we know is that it's more transmissible, maybe about 2 times more transmissible than the original variant, and could be slightly more than the 117 variant as well. Which partly explains the explosive growth in cases we've seen in India. and that on the clinical severity, there isn't really a good evidence. So this is where we need more systematic studies coming from India to compare the difference between this variant. So you need, very well done studies in hospitals that have looked at similar types of people infected with different strains to see if this is causing more severe clinical illness. And on the vaccines, there's some preliminary data coming mainly from lab studies,
Yeah.
which do what's called neutralization assays. You take the virus and then you expose it to certain levels of antibodies from people who've either recovered from previous infection, so convalescent sera, or people who've been vaccinated using a variety of different vaccines. And it does show that the virus is less sensitive to the antibodies, maybe 2 to 4-fold reduction
Okay.
in the antibody titers. However, that's not to say that the vaccines are not working. As of now, we know that even people who are getting infected after 2 doses of the vaccine are getting mostly mild illness. And so the vaccines generate a very broad immune response, and they help to protect against severe disease and hospitalization. So again, we need more careful studies in people because so far it's only the laboratory studies that we are seeing. And we need to follow cohorts of people to see after vaccination, how many of them are getting infected. We know from the US, for example, that out of 130 million people who've been vaccinated, there have been about 1,300 people who ended up in the hospital, and less than 300 of whom died. So it's a very tiny proportion of vaccinated people who are ending up in hospital and dying. So, on the whole, it's
I appreciate that. What I do want to press you on is you talked about this Indian variant and you talked about how it responds to the vaccine. And I know you said this as well. There needs to be more study. There needs to be more qualitative study to find out the effect of the vaccine on this variant. But I'm just curious to know if there is any evidence to suggest so far that this particular variant, the B1617, and its subdivisions 1, 2, 3, are less sort of reactive to the vaccines, at least the vaccines that are available in India, which is AstraZeneca and the Covaxin vaccine. Is there any evidence to suggest that they respond less to these two vaccines?
Well, there is evidence in the sense that there are a number of people who are getting the infection after getting both doses of the vaccine. I mean, we don't know exactly the numbers or the rates, per 10,000. So this needs to be worked out. So obviously there are people getting infected, and we knew that, no vaccine is 100% effective. What we need to know is how many of those people who are getting infected despite vaccination are getting ill, because that's the critical part. If you get a mild infection after vaccination, it's okay. You can live with that.
Sure.
What we don't want is people getting seriously ill, and that's what we really worried about. And at the moment, it seems that both the vaccines, the Covaxin and the Covishield, are protecting people against it. So I think we need to reassure people that as of today, the knowledge that we have today, the vaccines are working to protect you, because there's a lot of anecdotal evidence, saying, I know so many people who got infected. Yes, true, because there's a lot of infection out in the community. So people are getting infected, but the majority of them are not getting severely ill, or they're recovering from the illness.
And that's good. So since you mentioned the two vaccines, that's Covishield and Covaxin, India has just recently raised the gap between the Covishield doses from 8 to 12 weeks. It's gone up now to 12 to 16 weeks, similar to what the UK had done some months ago. Would that be in keeping with things? Would you be generally satisfied with that extension of the gap? Because there seems to be a school of thought which is suggesting that the only reason they're doing this is because of the lack of availability of vaccine or the shortage of vaccine, and not necessarily backed by science.
Right. So any vaccination program, both are important. The science is most important, but there are also operational considerations. Now, in the case of Covishield, there's actually data on different durations of gap between the first and the second dose. And the data indicates that the longer the gap, at least it's been studied up to about 12 weeks, the better the immune response. So the WHO actually recommends a gap of 8 to 12 weeks between the first and the second dose. And so I think 12 to 16 weeks is fine. The added advantage of that is that you can cover a larger percentage of the population. And many models and also experience from countries has shown that even one dose protects people to a large extent. And so getting more people covered with one dose is better than getting a smaller number of people with two doses. Now, this is not to say that, we know what's going to happen with immune responses beyond, say, 16 weeks. We need to collect that data. And also for vaccines like Covaxin, which were not tested at different durations, we need to do those studies. And people are doing those kind of studies now in other countries, as well as mix and match studies. What happens if you get a first dose with one and a second dose with another? This science needs to be done. We don't have the full data. But as far as Covishield and the gap between two doses, it is not going to affect. In fact, it may improve the immune response, and it will allow more people to get vaccinated. So it's a good thing.
So already, just as we are, hopefully coming to the end of this second wave, at least about 20 odd states across the country are showing a descendant trajectory as far as daily cases are concerned. Many top doctors here in India are already warning about a third wave, and a third wave which could potentially infect kids. Is that a pattern that you saw in other countries around the world as well? Because India seems to be about 3 to 6 months behind, countries like the US and UK, certainly as far as the second wave is concerned. So I'm just curious to know if you've seen this pattern of the third or fourth wave infecting kids.
Right. So third and fourth waves, yes, we've seen it in many countries. And I think we need to learn some lessons. And I want to go through that. Will it affect kids more? Well, what we've seen in other countries is that as the older people either are protecting themselves better, having learned from the past that they are the most vulnerable, or they're getting vaccinated because they come in the priority group. The age distribution of cases is gradually going down, and it's because of these reasons. Also, younger people are up and about much more. Many countries opened their schools and colleges, and so that all of that resulted in increased cases and better diagnostics and better testing. We weren't testing children that much in the first wave. And then you have a more transmissible variant where, one family member gets infected and many others get infected if, you're not careful. But what are the lessons we need to learn so that we don't go into a third wave? The first is that never let your guard down. We have to keep monitoring the trends very closely, and we need to adjust our public health and social measures accordingly. This virus isn't going anywhere.
Sure.
For many, many years. And so we cannot let our guard down. Second is we need national and subnational coordination mechanisms so that people are monitoring and acting on the same parameters. So like three important things is the number of positive cases that are coming up per week. What's the test positivity rate? What's the percentage of beds, ICU beds and oxygen beds that are occupied? Just these three things, you can explain to people also why you are making measures more strict or you're relaxing measures. Third is avoiding mass gatherings. Absolutely, we cannot afford to have any more mass gatherings till we're over this pandemic. The correct use of masks, especially when people are gathering together in indoor settings, of course, they should try to avoid that. So good, well-fitting masks worn at all times and good ventilation is important. And then the readiness. I think the lockdown period now in many states is to be used for preparing for beds, for reagents, for diagnostics, for oxygen, for pulse oximeters, increasing the workforce. We have to get more people. They're exhausted, that healthcare workers that have been working. We need to follow the science. We need to have guidelines on treatment, on prevention. Those need to be updated, as the evidence keeps changing. And then finally, we need to accelerate vaccination for the priority and vulnerable groups as quickly as possible.
One of the things that we're noticing, particularly in the northern parts of India, where a lot of people are recovering from COVID or post-COVID, they're suffering from what is being called mucormycosis or black fungus, colloquially. Again, this is not something that we witnessed in other parts of the world which saw second and third waves. So I'm just, curious to know if this is that there is something to worry here. Is this something that you saw in other countries, and what is causing this?
So this mucormycosis is a fungal infection, which generally infects immunosuppressed people whose immune system has, become low or suppressed due to, pre-existing illness or due to some drugs that they've been taking. It's rare. Now, as you said, we are seeing an increased surge in India. Why is that? There could be a few reasons for that. One is that Indians generally have quite a high prevalence of diabetes and pre-diabetes, and many of them are undetected and unknown. So many of the people who are getting COVID may not even know that they are diabetic or they are prone to diabetes. Secondly, the use of steroids. Corticosteroids are very useful in COVID patients who are severely or critically ill because it reduces the inflammation in the lungs. It needs to be given at a certain dose for a certain number of days. I think my observation is that steroids are being indiscriminately used. They are being prescribed. Maybe people are even self prescribing and taking them when they're not ill, when they don't need it. And doctors are also continuing it for long periods of time and at very high doses. And this is basically resulting in a complete damp down of the immune system of the body. And this fungus is everywhere. There are spores, fungal spores in the water, in the air, in the soil. Normally, our immune system manages these fungal infections without it, infecting us. But when your immune system is completely collapsed, then these fungal infections take hold. And unfortunately, it's a very severe thing. It has to be detected early, and both medical treatment and surgical treatment is needed. But I think it's a important point for people is not to take corticosteroids, oral corticosteroids, without a doctor's prescription, and for doctors to be extremely careful about whom they're prescribing, at what dose, and for how long.
Okay. Also, I'm curious about one other thing. Just recently, I think just a few days back, the WHO removed remdesivir as one of the lines of treatment for COVID-19. The expectation is the ICMR, which guides these things here in India, will also follow suit. Just a few days ago, we removed plasma therapy as a line of treatment. It's a very layman question. A lot of people out there are asking, this whole COVID treatment protocol seems to be a bit of a hit and miss affair. How would you weigh in on that?
So the evidence has been accumulating, right? We started with not knowing anything about this virus, which drugs will work. One thing we know that we don't have too many good antiviral drugs in general, for most viral infections, except for a few like HIV infection. So we started by saying, okay, which drugs can be repurposed? There were some anecdotal evidences, then clinical trials started. But towards the second half of 2020, we started understanding quite a bit. The first thing we knew was about steroids. In June of last year, we knew that corticosteroids can save lives when given at the right time to patients. And then we had these big trials coming out, including the WHO Solidarity trial. There were trials in the US, in the UK. And essentially, the Solidarity trial was the largest trial looking at remdesivir, and it showed very clearly, and India was part of that clinical trial, which was done in over 30 countries, showed clearly that remdesivir doesn't save lives, it doesn't reduce mortality, it does not reduce the duration of hospitalization, does not prevent people from progressing to more severe disease. And I think our guidelines is based basically on the data that's coming out of well-conducted trials, not from anecdotal evidence of physicians saying it works for me. Guidelines have always got to be based on a synthesis of the available data. Similarly, drugs like hydroxychloroquine, ivermectin, favipiravir, they've all been tested. Plasma therapy, there've been large trials, including the ICMR's trial. So the guidelines need to keep up with the evidence. And WHO, in I think it was October of 2020, made the treatment guideline on remdesivir, saying there is no evidence at the moment, at that time, to support the use of remdesivir in any group of COVID patients. And that's why it was taken off the list of drugs that had emergency use authorization. So that's an old recommendation. There's nothing new on that. But we are updating our treatment guidelines constantly. And if the evidence changes, we immediately go in and update that.
I'm also wanting to know your thoughts on the vaccination progress here in India. We started off very well. There were days we would do 3 million, 4 million even people getting vaccinated. But off late, in the last 3 weeks or so, it has slowed down and slowed down substantially. Of course, there is 1 billion plus people who need to be vaccinated. What would be your ideas, thoughts on how best to expedite the pace of vaccination?
Well, I think the limiting factor now is the supply. And I know that all the companies are trying their best to ramp up the production of vaccines. It takes time, it's complex making of vaccines. And so hopefully in the next couple of months, we're going to see not only these two, Covishield and Covaxin, increasing their supplies, but other vaccines as well, the J&J vaccine, the Novavax, which will also be made in India, by the way. All of them will by August, September, start coming into the pool. And at that point, I think can really ramp up vaccination. Till then, I think what's important is to prioritize the groups. And if you look at who are the people who are at the highest risk, they're of course the health workers, frontline workers. I think most of them have been covered, but there are other groups, like teachers, which we could consider, and then people above 45. That's the priority group. So in when there are limited supplies and constraints, you should prioritize the group that needs to be urgently protected, and then of course, it has to be expanded to all adults. And ideally, there would be a universal vaccination program that's run by the central government, as is done in most other countries. And cost should not be a constraint for people.
What is your best hope of how soon we can get a pediatric vaccine? And in the absence of that, your thoughts on opening schools and universities and so on?
So there are many vaccine developers who've already started their pediatric trials. And you may know that the Pfizer vaccine, for example, is now approved for children over the age of 12. And the trials in younger children are ongoing. And it's expected that in the next couple of months, the Pfizer, the Moderna vaccines will get approval. The AstraZeneca, the adenoviral vaccines for younger people, I think there's a bit of a slower development there, just because of these rare side effects that have been noted in younger individuals, given the adenoviral vaccines. But certainly other classes of vaccines are coming on board. And I hope that some of the nasal vaccines that are going to be made in India will be, they could be game changers for children. Easy to administer, will give you local immunity in the respiratory tract. So I'm very hopeful that ultimately we'll have vaccines for children, but that's not going to happen this year. And we should open schools when community transmission is down. That's what other countries have done. It goes, if there's not much community transmission, then schools are safe. Of course, you have to follow all the precautions. And if teachers are vaccinated, I think that will be a big step forward.
Okay. One final question, ma'am, and this is at a personal level. You've been working from Geneva for a few years now, ever since this outbreak happened. Your family's back here in India. At a personal level, what of these last sort of 18 months, what sort of a learning curve has it been for you?
It's a daily learning curve. I mean, every day you are learning more and more about this. And also from experience, I think being at the global level gives you a kind of an overview of what's happening. And the ability to learn and quickly adapt and help other countries to avoid the mistakes or to do things in a better way. The science has been truly amazing, and I've been very fortunate to be at the center of it, really coordinating the scientific, and the research activities of the organization, working closely with our emergency program colleagues, with our regional and country offices in different countries, including in India. It's been challenging and humbling. But I just feel very fortunate to have been in a position where, I could do my little bit in helping all of us really to face this pandemic together.
All right, Dr. Swaminathan, thank you so much. We're glad that we have you right at the center of all the research work going into the battle against COVID-19. Thank you so much for speaking with us here on CNN News 18.
Thank you, Zaka.